Hello, and welcome to the second of the 8 modules of the course on adolescent sexual and reproductive health for 2021. This module talks about contraception, counseling, and provision. My name is Marina Plesons, and I work with the World Health Organization's Department of Sexual and Reproductive Health and Research in Geneva, Switzerland. This slide presents the definition of contraception. Contraception is the intentional prevention of pregnancy by artificial or natural means. It enables people to attain their desired number of children and to determine the spacing of their pregnancies by delaying or preventing childbearing. There are a range of contraceptive methods, and these methods are designated by duration and context of use. For example, there are permanent, long-acting, short-term, and emergency methods, and by their mode of operation. For example, there are hormonal, non-hormonal, barrier, and fertility awareness-based methods. This slide sets out the rationale for providing contraceptive information and services to adolescents. Firstly, early pregnancies, both unintended and intended, among adolescents are an important problem. An estimated 21 million girls aged 15 to 19 years become pregnant each year. An estimated 12 million girls aged 15 to 19 years and 2.5 million girls under age 16 in low and middle income countries give birth every year. And approximately half of the pregnancies to girls aged 15 to 19 years in developing regions are unintended. The second reason is that early pregnancies among adolescents have major health and social consequences. Pregnancy and childbirth complications are in fact the leading cause of death among girls aged 15 to 19 years globally. Girls aged 10 to 19 face higher risks of eclampsia, puerperal endometritis, and systemic infections than women aged 20 to 24. An estimated 5.7 million girls aged 15 to 19 years have an abortion each year, the majority of which are unsafe. And we also know that the consequences are intergenerational. So we know that babies born to mothers under 20 years of age face higher risks of low birth weight, preterm delivery, and severe neonatal conditions. This slide presents global data on the adolescent birth rate per 1,000 women aged 15 to 19 years. On the map, you can see a sliding scale from higher to lower rates in countries around the world. And in the table on the right-hand side of the screen, you can see this adolescent birth rate for different regions. We can see that sub-Saharan Africa is the region with the highest adolescent birth rate at 104.4. That's followed by Latin America and the Caribbean with 63.0, and followed by Northern Africa and the Western Asian region with 40.5. This slide lays out 2 additional points of rationale for the provision of contraceptive information and services to adolescents. The first is that promotion of contraceptive use to address early pregnancies among adolescents has been shown to be effective. When correctly and consistently used, contraceptives can prevent unintended pregnancies and thereby reduce maternal and newborn mortality and morbidity. Additionally, male and female condoms can also protect against both unintended pregnancies and HIV and other STIs, sexually transmitted infections. Despite all this, though, laws and policies and the provision of good quality services need attention. 14 million girls aged 15 to 19 years in low and middle income countries have an unmet need for modern contraception. Contraceptive use in sexually active adolescents is lower than in other age groups for a number of reasons. Because of law and policy restrictions, because of a lack of knowledge gaps and misconceptions, difficulties in being able to access contraceptive services and commodities, and difficulties in wanting to or being able to use them correctly and consistently. Governments have a human rights obligation to provide contraceptive information and services to adolescents. States are obliged under human rights law to provide these services to adolescents and to adopt legal and policy measures to ensure that they have access to affordable, safe, and effective contraception. Contraceptive information and services should be free, confidential, adolescent responsive, and non-discriminatory. And barriers such as third-party authorization requirements, for example, should be removed. Finally, adolescents should have easy access to the full range of contraceptive methods. and such access must not be hampered by factors like marital status or providers' conscientious objections. This slide presents two key concepts to consider. The first is that laws and policies prevent the provision of contraception based on age or marital status in many countries. Critical to adolescent-friendly service provision are laws and policies that support their access to contraception regardless of age or marital status and without third-party authorization or notification. The second point is that many adolescents have misconceptions about contraception or do not know where and how to obtain contraceptive information and services. CSE is one effective way to reach and inform adolescents about contraception, but it should also be complemented by reaching out to parents, teachers, and other gatekeepers in the lives of adolescents. There are two other key concepts to consider. The first there is that contraceptive services and healthcare providers are often not adolescent-friendly. There's a need to overcome factors such as healthcare provider biases and misconceptions regarding contraceptive use by adolescents. The second point here is that the contraceptive needs of adolescents are diverse and evolving. Adolescents are not a homologous group. Instead, their complementary strategies must be used to respond to the differing needs and preferences of different adolescents. Additionally, programs must address the needs of special populations of adolescents, for example, those with disabilities or those who are migrants and refugees. This slide presents some of the key WHO guidelines that relate to contraceptive provision and use. There are numerous guidelines, as you can see on this slide, and these range from a guideline that's specific to adolescents, and that's the one at the top titled WHO Guidelines on Preventing Early Pregnancy and Poor Reproductive Outcomes Among Adolescents in Developing Countries. There are a few guidelines that are general about contraceptive provision and use to people of all ages. And these include things like the medical eligibility criteria for contraceptive use, selected practice recommendations for contraceptive use, ensuring human rights in the provision of contraceptive information and services, and, for example, WHO consolidated guidelines on self-care interventions for health, and specifically for sexual and reproductive health and rights. One key message to take away from these guidelines is that adolescents can use any method of contraception. There are no medical contraindications that prevent them indiscriminately from using any method of contraception, but more information is available in these guidelines. There are a few guidelines for specific population groups, for example, those for women living with HIV. And then there's some related contraceptive guidance in the WHO recommendations on health promotion interventions for maternal and newborn health. Finally, there are two guidelines that are of relevance here related to responding to children and adolescents who have been sexually abused and responding to intimate partner violence and sexual violence against women. All of these guidelines are available on WHO's website, and most of them, if not all of them, are available in a range of languages, most of them including French and Arabic. This slide presents a number of resources that are useful in complement to WHO's guidelines. Some of these are still WHO documents, but they're not formal guidelines. They may be program support tools or desk reference materials, and some are produced by other organizations, but have been deemed to be particularly useful to the field. Here we can see that there are medical eligibility criteria that's been turned into an application that you can use online or on your cell phone. There's also a medical eligibility criteria wheel that can be used that is a physical tool. There's a family planning global handbook for providers. There's an information note on self-administration of injectable contraception. And there's a training resource package for family planning that has a wealth of materials to support in-depth learning and training on family planning. There's also a task sharing guide to improve access to family planning and contraception. And there's a compendium of WHO recommendations for postpartum family planning. There's also an evidence brief on reducing early and unintended pregnancies among adolescents. Those are all the WHO materials. Then here are the few others that are from other organizations. There's Adolescents in Family Planning, What the Evidence Shows, that's produced by ICRW. There's something called the High Impact Practices in Family Planning, which has a brief on adolescent-friendly contraceptive services, mainstreaming adolescent-friendly elements into existing contraceptive services developed by USAID. There's a document on youth contraceptive use, effective interventions, a reference guide that's been developed by PRB, Population Reference Bureau. And then there's the Global Consensus Statement for expanding contraceptive choice for adolescents and youth to include long-acting and reversible contraception that was published by FP 2020 along with a range of partners. Just as with the documents on the previous slide, all of these materials are available in the public arena. The WHO materials are all available on the WHO website, and again, most if not all of them are available in a range of languages, including French and Arabic. The other documents are available on the respective websites of the organizations. As you heard last week from my colleague Chandra, UNFPA, along with a number of colleagues from WHO, developed a technical brief titled Not on Pause, Responding to the Sexual and Reproductive Health Needs of Adolescents in the Context of the COVID-19 Crisis. This was developed again in recognition that a number of services have been disrupted by the closures and disruptions resulting from the COVID-19 pandemic. And this document sets out some practical tips for governments and non-governmental organizations on how they can maintain and adapt services so that they can continue to be provided in the context of COVID-19. So some of the practical tips related to contraception are the following. Inform adolescents where and how to access contraceptive counseling and services, including changes, if any, to service delivery times, locations, etc., during the COVID-19 response. In health facilities, ensure that adolescents have access to the full range of contraceptive methods, including condoms and emergency contraception. Ensure that forecasting for commodities and procurement planning are taking adolescents' needs into account, and adjust for potential alterations in method choice. In case the preferred method is not available, which may certainly be the case in disruptions in supply chain, support the adolescent to identify an alternative method that meets his or her needs and preferences. Finally, consider waiving restrictions if such restrictions exist, such as those based on age, marital status, or parental and spousal consent, and consider providing services free of charge or at a reduced cost within the relevant legal jurisdiction and in line with international guidelines. A few more practical tips that are included in this technical guide. Consider providing multi-month supplies with clear information about the method and how to access referral care for adverse reactions. This can ensure that if there's difficulties in accessing services, adolescent clients don't have to come repeatedly every month to access the contraceptive method. Counseling and services should continue to be provided discreetly and confidentially to adolescents, especially if someone else accompanies the adolescent to the consultation. Consider establishing alternative delivery modalities for contraceptives that may be more accessible to adolescents, especially in the context of COVID-19 and movement restrictions. These might involve through pharmacies, shops, or even community-based delivery. And finally, consider setting up hotlines for adolescents, providing information and advice on contraceptive services, their self-use, their side effects, method choice, and other questions on sexual and reproductive health more broadly. The Not on Pause technical brief also provides some considerations for resumption of normal services in the context of COVID-19. So if and when services are able to return to some sense of normality, what are some things we need to take into account? First, we need to enable adolescents who had to pause their contraceptive use or change their methods because their preferred method was unavailable to return to their preferred method. And where possible, we should consider where we can promote the institutionalization of good practices in improving accessibility and quality of services that were put in place during the period of closures and disruption. This is the final slide of my segment of the presentation before I hand over to my wonderful colleague, Khalid. And it shows a cartoon presenting a very common situation that may resonate with many of you. It's a training session with a group of health workers, and one health worker voices her opinion that she believes contraceptive methods should not be given to young women until after they've had their first child. The trainer corrects her based on the evidence and says that that's not true based on the evidence. And he says that it is safe for all young women to use contraception even if they are not married or haven't yet had a child. One of the other health workers in the training responds, yes, and it can help them to avoid unwanted pregnancies. This echoes many of the issues we discussed earlier in the presentation and that you'll read about in some of the course readings for this module.
Dear course participants, I am Khalid Siddeeg. I am the medical officer in Child and Adolescent Health Unit in WHO Regional Office for the Eastern Mediterranean, and it gives me great pleasure to be part of this training course and to present to you the regional perspective of contraception, counseling, and provision. Let's start with some key facts about contraceptives in our region. The Eastern Mediterranean region is having the second lowest contraceptive prevalence rate, which is less than 50%, and the second highest unmet need for family planning globally. This is after the African region. We have 10 member states in our region that having their unmet needs for family planning exceeding 20%, and also 9 member states are having their CPR lower than the regional average, which is 48% mentioned above. The issue of early marriage in our region is a big challenge, and we see in countries like Somalia, like Sudan, like Yemen, we have very high rates of early marriage, and this for sure putting great challenge on the contraceptions used for young girls. And also in addition to that, we are having one of or some of the highest adolescent fertility rates in countries like Sudan, like Yemen, like Somalia and Afghanistan. They are exceeding 60 per thousand adolescent girls, the adolescent fertility rate, which is pretty high. In terms of policies and programmatic situation in the region, we see there are lots of issues around policies and legal aspects when it comes to the contraceptives for adolescents. We have, for example, 3 countries in the region that have national policies and guidelines that prohibits access of adolescents to contraceptives based only on their ages. We have also around 7 out of 16 surveyed countries in the region. They have contraception policies that require disaggregation of data for adolescent age group. That means 9 of the 16 surveyed countries, they don't have this disaggregation of data per adolescent age groups. Also, we have around 1/3 of the countries in our region that they don't have adolescent health as part of the training for clinicians, for nursing and community health workers. In this slide, we will highlight the regional challenges in provision of contraceptive services, and we have grouped them into 2 categories: sociocultural challenges and policy and programmatic challenges. For sociocultural challenges, we have issues like high rate of early marriage, as we mentioned in the previous slide. In fact, for example, the Arab region, we have more than 40 million young girls who got married before reaching age of 18, and for sure this high rate of early marriage is putting great challenges on the service provision to young couples, and also some other sociocultural barriers. For example, we have famous misconception in the region that young couples should not use any contraceptives before having their first child, in addition to so many other misbeliefs and myths and misconceptions. And as you may all know, that our region is home for many humanitarian crises in the world, and we are having around 62 million people across the region who are in need of health services and need of humanitarian assistance. And more than 50% of our countries are directly or indirectly affected by humanitarian crisis, and this for sure is making provision of services to women, children, and adolescents in general is a challenge, but specifically for young couples who are seeking contraceptives, that will be a big issue in those settings. As for the policy and programmatic challenges, we have issues related to laws and policies, as we said also earlier. Issues like restrictions based on age, restrictions based on marital status, and so on are prevalent in the region. The issue of access to quality of services, because we know that providers are not well trained. In many instances, supplies and equipment are not available for provision of the service, and also the issue of lacking of data, specifically the disaggregation of data by age and by sex is a big issue in our region that needs to be solved. The outcome of all these challenges mentioned before is shown in this slide. As we see here, the slide shows the map of adolescent fertility rate per 1,000 girls, and it is clear that in countries like Sudan, Yemen, Somalia, and Afghanistan, we have adolescent fertility rate that exceeds 60 per 1,000 girls, and in other countries which have less rates than 60, but still high. For example, Egypt, Iraq, Pakistan, Syria, and Palestine. The map shows that a lot of work needs to be done to address the issue of contraceptive use among adolescent couples. And here is another map that shows so many countries in our region that having issues with demand for family planning, and we see that quite a good number of countries they have less than 50% of the demand of family planning satisfied with modern contraceptives. This is for women in the reproductive age 15 to 49. Regional initiatives in our region are so many, and this initiative here from Egypt shows that our region started working in this area a long time ago, and this is a contraception social marketing project in Egypt called Family of the Future, and it was established with the objectives of increasing the awareness and demand of family planning services through contraception social marketing, and also to establish and maintain a reliable supply of family planning commodities in pharmacies, in the private pharmacies. And it was using strategies such as intensive media-based advertising for the products, and also by subsidizing the prices that are sold in the commercial market. And when you look at the outcomes, you see only in 3 years, as per this audit that was conducted in 1981 to evaluate the project, all the contraceptives product sale was increased by at least 3 times, or around 3 times for all the products. So it shows success, and also, as I said, that it gives us a clue that the history of interventions in this area is old in our region, and people started working decades ago in this area. It is important to note that we are not working in a vacuum, and we have several opportunities in the region that we can build on and make benefit of. We have the Global Strategy for Women, Children and Adolescent Health 2016 to 2030, and in our region we have supported countries to develop their own plans and to adapt the interventions of the global strategy to their context, including interventions for maintaining contraceptive services and also ensuring provision of services to adolescents. In addition, we have the Accelerated Actions for the Health of Adolescents, the AHA framework. Also in our region, our member states in 2017 passed a resolution that urges countries of the region to develop their national strategic plans for adolescent health, and by now so many countries started this process and they are having their national strategic plans ready, and we made sure that those strategic plans are addressing sexual and reproductive health, including contraceptive provision for adolescents. Here for this slide, last but not the least, we are having our regional implementation framework for newborn, child and adolescent health for the period 2019-2023, which is having 3 strategic areas, and across all the strategic areas we find the work with adolescents and for improving adolescent health services is very prominent in the framework, and in the service package proposed in the framework, we have sexual and reproductive health and contraceptives are key parts of that service package. In order to address regional challenges mentioned earlier, we need to consider several interventions related to adolescent contraception. Here are some examples for the area of child marriage and early marriages. We think that the comprehensive approach is really important for this area. We need to have aspects of policies, legal interventions, and also programmatic interventions put in place, in addition to community engagement and preventing gender discrimination and so on. Also, we need to make sure that we are engaging all sectors and having a cross-sectoral approach to approach the issue of contraceptive use among young couples. And here we see the sector, the education sector, having a great importance in this process. The area of stigma and eliminating the myths and misconceptions about contraceptive use, here the community engagement is a key intervention, and we need to make sure that parents, teachers, religious leaders, all of them are involved and they are having the correct messages, and they are having the capability to convey the correct message to the community. In addition to that, coming to the service part of the problem, the issues of accessibility and acceptability of the service to adolescents is very important, and we are calling for countries to make sure that adolescent-friendly health services are available and are integrated within the existing platforms. For example, are integrated within the primary healthcare services. And in some areas, the use of mobile outreach services could be a solution for the issues of access of adolescents to the services. In humanitarian settings, we already have the MISP package, the minimal initial service package for reproductive health in crisis, and we feel that it covers appropriately the issue of sexual and reproductive health. So adopting this package in humanitarian crisis might lead to increasing and improving accessibility of services by adolescents. Again, we need to make sure that we are having meaningful engagement of youth, both in the implementation of programs, but also in data collection. And we need also to ensure that data is being disaggregated by age and sex across all countries. In this slide, we try to shed some light on the impact of COVID-19 pandemic on contraceptive services. COVID-19 pandemic affects contraceptive services across so many dimensions, across dimensions of supply, demand, and availability of services. As for the supply, we noticed that, or it has been observed that COVID-19 has affected the supply and has disrupted the supply provision of contraceptives and also the transportation of contraceptive commodities due to prioritization of other products. And also we have seen that all the data has shown that there are issues with the demand, especially within the lockdown period. And in terms of diversion of services or closure of services, that was also observed in many settings because unfortunately in some settings it was considered as non-essential services, and sometimes health workforce working in this area are moved to serve other parts of the health facilities. It has been estimated that if we have 10% global decline in the use of reversible contraceptive methods, this might lead to more than 48 million additional women with unmet needs for modern contraceptives and more than 15 million additional unintended pregnancies. These are really huge numbers, and thanks God that so many interventions were put in place trying to alleviate this problem, and hopefully we will have some success in maintaining the provision of services during COVID-19 pandemic. And these are some examples from countries in our region. We are showing these examples from Pakistan and Sudan, and it shows clearly that the provision of oral contraceptives in months of April and May, which are mainly in June, which is mainly the second quarter of 2020, the service has declined significantly in this period. So it was clear that there was a reduction, but the good news that countries managed to catch up in various paces, but in fact so many countries managed to catch up and to overcome the effect of the service disruption during the peak of the pandemic. By this, we come to the end of this presentation. I wish it was useful and meaningful to all of you. I would like again to thank all of you for joining this training, and I would like also to thank my regional colleagues who put together the regional slides. I wish you all a successful and fruitful training journey. Thank you and goodbye.